So it's my pleasure to introduce Bruce Wingus. He's the editor and vice president of the Akron Beacon Journal for the next session. Bruce, you're going to do the introductions of everybody? Okay, here you go.
Jan wants us to move fast today, so we'll do that. Just move, okay. Following that panel, here's what we want to do with this panel, is we want to look at the opiate crisis through the lens of those who deal with the issue on a professional level in the medical community and on a personal level also. I want to talk about what the ethical issues are in the medical profession on those dealing with the crisis. What about those who teach the next generation of medical professionals? And the families who face the fallout from this. And where are the lines between telling stories of families in crisis and exploiting those families? I want to get into all those questions with our panel right now. And so I'd like to start by having our panelists introduce themselves. And as you introduce yourself, let's answer this question. How do you define the opiate situation we face today from what you see and what you experience? Start with Greg.
Hi, I'm Greg McNeil, and the reason that I'm here today is because I lost my youngest son, Sam, to a heroin overdose 3 years ago. And as a family, we really felt as though we had things covered. As soon as we learned that Sam had an issue, and after a innocent prescription to pain pills, after surgery, after we found out that that led him down the road to addiction and ultimately to heroin and buying heroin on the street, we went into crisis mode. And, you know, we did what we felt like is presented in the media, and we felt like we pretty much knew. Find a great rehab facility and get him in there. That's what we did. So Sam went to a rehab over in Akron. He went through the program. He learned a bunch. He came back home after that. And, you know, we were thinking, gosh, that's a blip on the radar screen. Now we can go on about our lives. Well, about 6 months later, he relapsed. And this time, he went a little bit deeper. And we scratched our heads and we thought to ourselves, you know, this just didn't work doing this locally. So what are we going to do? Let's go ahead and send him away. So we sent him to Boca Raton, Florida, to another rehab facility. And once again, he went through with flying colors. And about 6 months later, we could see it looked like he was going to make a turn for the worse, and somehow he met a wonderful woman. They fell in love. He got the job of his dreams, and he was rocking. He was doing really great. And we thought, wow, we dodged a bullet here. We're on about our business here. We're on about our lives. Well, on October 23rd, 2015, he kissed his girlfriend goodbye that morning. She went off to a church retreat. It was a Friday, beautiful fall morning. He went into work about midday. He pulled aside his boss and asked if he could have the afternoon off. Said he wasn't feeling really great. His boss said, "Sure, Sam, no problem. We'll see you on Monday." Well, at 12:30, he sent a text to an old dealer that used to provide him with his stuff. He got a text back that night. That was his last text from that same dealer saying, "Yo, you good." They found him the next day. He was gone. He was gone. He was all alone. He was in his game room, and he didn't even have a chance. The stuff that he got that day was heavily laced with fentanyl. And my family was devastated because we just felt as though it was covered. We felt as though we were on top of this, but boy, we were just so woefully ill-prepared for this and ill-prepared to support Sam in his recovery. So what we've done is we established a foundation. It's called Cover 2 Resources, and it's called Cover 2 for two very good reasons. Number one, Sam loved football. He was a defensive back on his team. And for those of you that follow football, you know that's a defensive scheme. But probably most importantly, it's because we felt like we had it covered. We didn't, but doggone it, for the next family out there, we're going to provide the education and advocacy so that they will have it covered, and so that their lives will not be dramatically changed. And so as part of that, what we've done is our first initiative really has been a series of podcasts. We call them the Cover 2 podcasts. It's a podcast series about people, places, and things that are making a difference in the opioid epidemic. We've now produced about, I think it's 205 of those episodes. And I tell you what, we've been so blessed to meet some incredible, incredible people that are making a huge difference in the opioid epidemic. And we've been fortunate enough to find out about programs that are working really, really well in many different areas of the country. And we've brought them back and talked to them we've talked to leaders here in Northeast Ohio about those programs, and there's been a number of them that have taken root back here. And you know what? My son I just feel his presence with us every time that something hits because he's working overtime up there. I got to tell you. So, how do I define the opiate situation we face today with what I see? Addiction treatment is really big business, and don't mistake that. It's really big business. And you know what? In the first year of attempts to recovery, there's somewhere in the neighborhood of 90% of people that relapse. And when you think about that, the odds are huge. And for treatment providers, there's actually a disincentive for people to recover when you really think about that. So, because if people recover, then you lose a client there, right? You lose a patient. So it's really, really important to have somebody advocate and look and watch for, treatment and vet your treatment providers. So that's one thing. Medication-assisted treatment is, how am I doing, Bruce, on time, by the way? Okay. Medication-assisted treatment, that's considered, I think in the early session, they talked about how that's considered the gold standard now for treatment, right? I mean, they use it in drug courts. We've got over 3,000 drug courts, by the way, across the country now. And people are finding that for some time, they can be successful with that. Why? Because those intense cravings, it keeps them at bay. So they get a chance to get some recovery capital under their belt, okay, while they're trying to recover there. Yet, 4% of physicians in our country today are trained up and licensed to be able to prescribe buprenorphine. Just 4%. That's got to change. Pharmaceutical companies were wined and dined physicians for over 20 years to get them to prescribe opioids. So that's the culture that we're in today. That's reality. So we have to be really vigilant in terms of going after our physicians and having them take that next step and make it easy for them to find alternatives and prescribe alternatives to pain, such as they've done over one of those programs I want to describe here real quickly, with the Alto program in Paterson, New Jersey. It's St. Joseph Healthcare. What they've done is in New Jersey, this is the number one ED, the busiest ED. They see something like 300 patients a day. And what they've done is they've trained up all of their attending physicians, this is 75 attending physicians, on alternates to opioids for pain management. So what happened? They prescribed 50% less right away, right after that. So those are the things that are really making a difference, but that's the state that we live in today. Rehab is really big business, and as such, with that whole backdrop, what I see today is a huge opportunity to redo and rework how we address addiction in our healthcare system in our country. And this is something that you as journalists have an opportunity to weigh in on. You can make a difference there. And it's how you tell that story and how you look for some of those great programs out there that are making a difference.
I'm Michelle Bestick. I'm a clinical toxicologist at Akron Children's Hospital. I originally, my path to the addiction world is somewhat unique in that I don't have any personal experience with addiction. I kind of fell into it. I went to pharmacy school, and then I did a postdoc in pediatric toxicology up at Rainbow Babies with the Northern Ohio Poison Control Center. And, as far as the opioid epidemic, when you're in a poison control center, you take the call and you tell people what to do, and then that's kind of the end of it. There's not a whole lot of follow-up from that standpoint. I moved on to Akron Children's in 2008, and suddenly these overdoses were in the walls of our building. And it wasn't right in 2008. I will tell you that the addiction world hasn't changed, the drugs change. So I was still seeing overdoses in 2008, but it may not be opioids. I still see overdoses today, and usually they're not opioids. But suddenly at Akron Children's, we had our first patient with a full-blown heroin addiction in the walls and had 2 life-limiting, debilitating diseases. One was addiction. And he needed treatment. And so I did what I normally do. They consult us. So we get consulted from the ED, we get consulted from the PICU on management of patients, medications to administer, whether or not they're safe for discharge, whether they need to be admitted, recommendations for resources. And I made these recommendations. Okay, he's in withdrawal. Let's do X, Y, and Z. And I was met with a big, we're not going to do that. We don't think we should treat that kid. And we had a lot of meetings, and there was a lot of pushback on whether or not he should be allowed within the walls of our hospital or pediatric institution. Maybe we shouldn't treat him. Maybe we should send him out to a different facility. And I'm very proud to say is that our senior leadership has really taken it upon themselves to change those conversations. We've had a lot of heart-to-hearts and dealing with what leads to addiction and that it is a disease and recognizing that. And so for me, it's changed greatly in that just the acceptance. I don't deal with the NICU as much because they have their own personal people over there that handle all the neonatal abstinence babies. But I can see the compassion and the empathy growing for a lot of these parents. I can see the compassion for our patients that come in is increasing. And like Lieutenant Garrow said, sometimes there is a little bit of compassion fatigue in there. They're not always the easiest patients to deal with, but they still have a disease. And where it stands today is I haven't treated a inpatient opioid overdose from an adolescent in probably 1.5 to 2 years. So I would echo that Lieutenant Garrow is seeing. That doesn't mean that my overdoses are down. My overdoses are the same, and my suicides are the same, if not increasing. They're just moving on to a different substance. I've treated 5 benzo addicts in the past 3 months, and I've probably treated 3 heroin addicts in the past 4 years. So for now, it's just changing. Addiction stays the same. The risk factors stay the same. But in the tox world, we always say what is old is new again. So meth kind of went away, and it's coming back. Benzos kind of went away. They're coming back. Cocaine kind of stays similar. I don't know why that is. Quaaludes have never made a reappearance for some reason, but everything is old is new again. And so we just continue to fight from an addiction standpoint instead of necessarily an opioid standpoint.
Hello, my name is Julie Altman. I'm a clinical ethicist, philosopher, and medical educator at Northeast Ohio Medical University. And I'm coming from multiple perspectives, from education, from research, from policy development, and bedside consultations. And those dimensions are just the surface of this crisis, of the addiction, of the mental illness, of all the social determinants of health that contribute to this problem. And so from the clinical consultation part, I can honestly say that over the past 5 years, the number of consults have increased. And my fellow ethicists that are sitting out there can attest to, we've been doing this 15, 20 years, serving 4 different hospitals, 5 different hospitals in our area. And historically, we see typically end-of-life cases, the elderly patient who's struggling with removing the ventilator. But now, when I'm presented with a consult, it's a 20-year-old, it's a 30-year-old that has endocarditis due to IV drug use, who has blown out his heart valve, and a surgeon is saying, do I have to do another surgery? Or a surgeon is saying, we need to do the 3rd heart valve transplant. The other cases that I see from a research perspective, and I want to give a shout out to my colleagues at both Kent State University and Neomed, Lynn Folletta and Rebecca Fishbein. We have been working for several years on various projects with pregnant women and the opioid crisis and the recidivism that we do see and the need for social justice to not only take care of these individuals, but their future. And working with multiple dimensions from Child Protective Services to law enforcement to legal counsel to our healthcare partners at Children's and SUMA and Akron General and so forth, it does take a village. And you asked to define this. You cannot define it with one single factor. The research that I've been doing just in the past 5 to 7 years with clinicians, social advocates, social scientists, we're just tapping the surface of this stuff. And we can give you guys data, we can show you that there is a need for ethical guidance, but from a definition standpoint, it is so complex that you have to look at the multitude of folks, expertise, and the individual stories. I think that sometimes we don't value the individual patient. We focus on populations, and that's not a bad thing, but when you get down to the nitty-gritty and who's at the bedside or who is in the bed, every story is different. And if you have a support system, a family support system, that is great. But I'm seeing folks without any support system. And, we're unfortunately seeing this as an increase of people leaving each other, families leaving each other. So it's complex. I know you have a lot of questions to get to, but I can talk from multiple perspectives.
I'm Dr. Pat Ensminger, Dr. E for short. I'm a 30-year doctor of chiropractic in the Youngstown, Warren area, also returning for the first time in 35 years to my alma mater here at Kent as a zoology major. I changed my mind, as so many students do. The Northeast Ohio region is one of the hardest hit by Ohio's opioid epidemic. And in my opinion, contrary to some of the remarks, the opioid issue is still very much an issue in the Youngstown, Warren area. I attend the county meetings, and that's often foremost. It doesn't mean these other substances aren't out there, but that is. And speaking as an alternative healthcare physician, I can tell you that the attitude, not so much within the hospitals, but within the private medical clinics, is still very intolerant of the whole issue, ignorant of the whole issue, and that's part of my message here today. My wife and I have done what we can, as have so many parents, to see our 2 teenage children at Howland High School. Samantha says hello, Amelia. Hi. We've done our best to see them through to adulthood opioid-free, and that's at the height of this opioid crisis. I am the co-chair of the Ohio State Chiropractic Association Opioid Task Force. My association and my task force have twisted Governor Kasich's arms sufficiently to name September as Ohio's Drug-Free Pain Management Month. I'm also president of the Eastern Ohio Chiropractic Society. As far as how I see this crisis, I'd like to start with a question for you. And there's a door prize involved, one of my opioid pens. So name the author of this famous quote if you can, and you win one of these marvelous pens. Those who do not remember the past are condemned to repeat it. And I'll accept two different answers. Anyone, anyone, anyone. Way back there. If I throw this, you're going to be hurt.
George Santayana.
Well, very good. Stolen by Winston Churchill as well. But it was George Santayana.
Is Dr. E also an acceptable answer?
I did not steal it. I name the source. So I see the opioid crisis as a problem 3 decades in the making, starting with the pain revolution in the 1980s, when doctors began to seriously address the issue of pain and seek effective ways to deal with it. Drug-free doctors began to seriously address the issue of pain as well, with approaches involving lifestyle modification, exercise, and diet. Despite this and the effectiveness of these approaches, they were largely dropped. They were dropped because of the perception that patients would not comply with such complex recommendations and interventions, and that insurances refused to cover these approaches because they were perceived as higher expense relative to pain medications, a problem we still face today. The pain revolution gained traction in the 90s, and pain medication, including opioids, skyrocketed. Pain care became mandated as the Joint Commission, the hospital accreditation agency, adopted pain as the 5th vital sign, requiring physicians to address pain with the same diligence as a person's heart rate or respiration. January 1st of this year, the Joint Commission, which hospitals are required to follow to maintain their Medicaid and Medicare acceptance, partly out of embarrassment for this long-standing recommendation to aggressively address pain with medication, stated for the first time ever that hospitals are required in their emergency departments and other departments to provide recommendations to education regarding drug-free alternatives to pain management. I've been working aggressively on this topic. I can tell you that it is largely not necessarily in a villainous sort of way, but being ignored by the hospital community in favor of other issues. Drug companies, again, began heavily marketing opioids, such as OxyContin, to physicians, claiming they were largely non-addictive. Purdue's statement was less than 1% addictive. Opioid use took off. Carry forward 25 years to the largest and most expensive public health crisis we have ever faced, and you realize those pioneered drug-free pain management methods don't seem so expensive or complex after all. So what has modern medicine put forth as the answer now? And I would like to say that I believe one of the most immersed individuals in this topic that you will ever meet is Greg McNeil. So I slightly apologize that I'm about to rain on a comment he made a little bit, but the current wisdom within the hospital and medical community and emergency departments is a program called ALTO, which is an admirable program. That is alternatives to opioids. Dr. New Jersey Jewish Community Hospital.
St. Joseph Healthcare.
That's it.
Dr.
Okay.
Rosenberg. Yeah, Mark Rosenberg.
It is a set of protocols for dealing with common pain presentations within emergency departments. It's being widely considered and accepted nationwide. Now, my comment as a drug-free practitioner is that every Alto solution is another drug. They literally take the top 8 or 10 presentations and say, instead of opioids, gabapentin or what have you. I reached out to the author of Alto and suggested that chiropractic care and other drug-free care has an important place in those protocols, and to date I have received no response to that inquiry. Thank you.
As you're all talking, as the previous panel spoke also, we're kind of dancing around this issue of culture change in the medical community. And you touched on a little bit at children's. Is the culture change keeping up with what needs to happen to treat this successfully in the medical community, and I can ask you all from the inside and Greg from the outside. Anybody?
You want me to start?
Let's start with one of the...
Okay.
You want to start? Yeah.
So, yeah, I mean, there's still pushback, there's still resistance. You are always going to encounter people that have their own experiences in dealing with an addict or their own experience. I always liken it to weight loss, to people that want to understand it. There's always that person that went carb-free and lost, 100 pounds, and it worked for them. And there's always that person that tries the carb-free and it doesn't work. And so sometimes addiction medicine is a little bit like that. But if that's been your experience that, hey, I went carb-free and I lost 100 pounds, sometimes it's hard for people to get off that narrative. And sometimes it's hard for people to get off a narrative that Jesus is going to save someone, and not that that can't save someone, or that this is going to save someone, or that this is the beneficiary. But just like all complex problems, there are a lot of different solutions that work for different people. And so when we're dealing with individuals, we're still individuals treating individuals. We bring all of that with us. We bring those prejudices. We bring that experience that we've had. Sometimes those prejudices are good. Sometimes they're not so healthy. And you just have to keep fighting and keep pushing and hope that your patient ends up with the right group that works for them right now, because right now there's a lot of silos in the addiction world. This person's doing this person's doing this, this person's doing this, and it makes it difficult. Sorry, you had a question?
Yeah, so with down in Cincinnati, we hear a lot of the people who go into the hospital are treated poorly.
Right.
And we hear that a lot of people in the hospitals, nurses, they don't see the person with addiction. They're treated poorly. So my question is there enough training going on within the hospital environment to accept these patients? I mean, we've heard of these guys. They walk away because they're not they're.
Right, and I will be the first to claim we're not a perfect institution. And like I said, sometimes my last patient hurled more F-bombs at me in 5 minutes than I probably heard all year. But so we personally have a quarterly series for all of our nurses that deals with drug abuse and addiction, not just opiates. We've had probably 3 or 4 Schwartz rounds on at least an annual basis. Schwartz rounds are meant to bring compassion back into the medical community, and so we share in a non-judgmental way our personal feelings with the issues we feel surrounding these. And from our very first one to now, it's changed dramatically. And so I've done grand rounds at least 2 or 3 times dealing with it. And we have a leader in Sarah Freebert who is a force to be reckoned with sometimes. And she is a true, compassionate, empathetic person who leads the charge. And sometimes it's hard to ignore her plea. So we do what we can. We have a lot of groups to focus on that compassion fatigue. Not to say we're perfect, but yeah, I still see it. I still see nursing staff roll their eyes at the kid. And that same kid that hurled a lot of F-bombs at me broke down in tears that he wanted his mom 2 minutes into the conversation. So it's a lot easier to hold those beliefs when you're not face-to-face with these patients. So the people that deal with it on a day-to-day basis, I think it starts to hit home. But sometimes on the outside looking in, you just hear this story and you think, right? You go back to that, why don't you do drugs? Don't do drugs. And it just doesn't work.
So I had the privilege of doing a podcast with some people from Mercy Health in Cincinnati. And they have solved a couple of unique problems. And they've done a great job of collaborating with other providers in Hamilton County in doing so. The first problem is lack of availability, perceived lack of availability of beds. And what they determined was that there wasn't a lack of availability. What there was a lack of knowledge. Because this is so dynamic, the resources that providers have available change every single day. And what they're doing changes every single day. So through an app that they developed at findlocal.com, they figured out a way to motivate all of these providers to update their availability on a daily basis, and it only takes them like 5 seconds. It's incredible. So it's a very effective app. So they took care of that problem, and so they instituted this program that they call Treatment on Demand, and so they want to make it available on for all of their major practices throughout Mercy Health. And this starts at the ED. So somebody comes in to the ED, bam, they hook them up and figure out where they can get treatment, and also they go ahead and start on Suboxone right there in the ED and take them from there. So it's a really great example of an organization that, number one, has solved a huge problem. Oh, by the way, also another big problem that they solved. You have all these providers out there, right? In their case, they've got 17 different providers that they work with in Hamilton County, so treatment providers. And so before, you had an issue of assessment. Assessments took a darn long time to do, 75 minutes or longer. So these people that are hurting, they can't wait through all that. You lose people that way. The quicker you get them into treatment, the more effective you're going to be. What they did was they got everybody on Epic, their system, so they're all looking at the same stuff. And they reduced it to less than 15 minutes. Bam, they're able to get people in right away. So that's an example of a healthcare provider that's thinking about doing the right thing, and also, by the way, they're real happy to share it with others. And I think getting outside of our silos, Michelle, as you called it, getting outside of that is just critical here, because it's affecting us all.
Julie, do you see that culture change, and do you see it in what you're teaching also?
There is an emerging culture change. I would not say this is a fast culture change by any imagination. And I really want to bring up something that's important, that we keep on separating patient and provider. A part of my obligation as a medical educator is to teach young healthcare professionals about addiction themselves. And what I've been privy to as an ethics expert on some legal counsel and legal battles, as well as medical education, is that providers are struggling. Providers are writing their own prescriptions for opioids. Providers have addiction. And this is not just a single patient-provider experience. This is a provider who might need additional help in order to be the one who's then helping their patients. And whether it's working with state medical boards, providing education to healthcare professionals, whether it's recognizing burnout, moral distress, and all the things that go on in the clinical experience, the factors are just really complex. And if we can't call attention to the providers that are struggling, how are we supposed to help our patients? And so part of what I do at NeoMed for our students is actually have a panel of healthcare professionals, pharmacists, chiropractors, physicians, and they will tell their stories about addiction. They will tell their stories of how, a ski accident and having a prescription ended up on IV heroin use. And so from that perspective, I think we're starting to see the emergence of change. The other, our legal community, for those lawyers that are out there, kudos to them, because we're working, ethicists and lawyers are working together to make sure that when there are pain clinics or hospitals and individual healthcare providers that are struggling with identification of addiction, monitoring medication management, monitoring addiction, knowing how to see addiction, I think lawyers, even though sometimes physicians think lawyers are scary, have actually been an asset in trying to make sure that we're recognizing and managing addiction in ways where we're held accountable, legally, ethically, and socially accountable. So.
And Patrick, I'm assuming you haven't got that answer from New Jersey that you're still waiting for. You ran into a wall there. How do you see the culture changing?
Still monitoring my phone, actually. But, Well, first of all, the barriers, the cultural barriers that that are prevalent for chiropractors is that we do believe we have an answer, but it's an answer of prevention. It's an answer that could have been in place for the last 30 years, providing a predominance of pain presentations in emergency departments with a solution that didn't even involve medications. That's not everyone, but that's a lot of them. And generally speaking, recommendations to chiropractic care have been non-existent within the medical profession. So my task force and my profession in general are attempting to overcome these historic barriers that have existed between chiropractors and the medical profession, between chiropractors and the public, between chiropractors and the media. And I certainly have remarks about that a little later. I wear my opioid pen in public all the time. And it's an interesting social experiment. I can be in line at Giant Eagle and have someone walk up and say, quote, "All those addicts are making it hard for those of us who need the drugs to get them." Now, I read that a little differently than the way it might have come across in the remark. I had the director of a major pain management facility at a meeting recently put his arm around me in confidence with maybe a couple of drinks in him and say, "This opioid thing is overblown. Once it settles down, we can get back to business as usual." This was a CEO. Usually I would actually say who. I've become a little bit more sophisticated. So yeah, I admire, I believe, what the hospitals are doing. And I've also had dealings with the Mercy administration, Cincinnati, and in my area. And their pain team, their opioid team, that is just outstanding in terms of what they're doing. But I can tell you that I've met with them on multiple occasions trying to implement a program where their emergency department would provide recommendations for drug-free care. They're obligated to say you should see your family doctor, but there's no harm in also saying, but you could consider chiropractic care for this problem. It's low back pain and sciatica. And what I usually get there is, we'll have to consult legal. We'll look at our bylaws. It's still on their list, but it's way down on their list. So yeah, I believe that we are encountering a lot of barriers regarding this as well.
Question, if a person or family is reluctant to acknowledge a problem, how do you move that person toward treatment? And we'd also talked about shaming earlier in the day. How do you get past that and get them toward a solution here and keep your ethics intact? How does that work? We'll start with you, Michelle.
So right now we focus on acute care. So we see the acute overdoses, or we see the kids that are admitted for other medical reasons that are going through withdrawal. We are in the process of establishing outpatient clinics. And so it's one of our biggest frustrations, and not just from an addiction standpoint, but from a mental health standpoint. We have a lot of resources when someone comes in from an overdose that's suicidal, that we can admit them to a psychiatric facility because they're a danger to themselves, or because they're homicidal or suicidal. And the law supports that time and time again, and most of the time our parents are okay with that. But when we do have some issues where the parents refuse treatment, we can JR6 them, we can basically hold them against their parents' desires and admit them into a psychiatric facility. Those same things don't exist for addiction. And so unless someone is actively suicidal or homicidal, you can come in with an overdose and refuse to get treatment. And a lot of times we are discharging you with the hopes that you're going to make your follow-up visit in 3 days, or the wait time has shortened significantly. Before it'd be 3 weeks, 3 months. Now we've gotten to about 72 hours for our last couple kids. And so it's always this struggle, because when you send these kids home, I don't know of other disease states where I send them home and hope they don't die tomorrow. And that's essentially what we're doing, but I don't have any other recourse unless they're involved with the law. And so sometimes we're begging parents to press charges on their kids. Could you please maybe file something against that $5,000 you stole? And that's a big step for a parent to do, especially when maybe this is the first time they've had to face the abuse or the addiction head on. And so that's a constant struggle for us, is that I've sent a girl home whose father was trafficking her and who was sharing dirty needles. We didn't send him home to her home to him. We sent her home to a different family member who still gave her access to her father. And so it requires a lot of legal maneuvering to really get involved with these kids, to get them somewhere, because they're not suicidal. The law's not on our hands. It's a constant struggle.
So some of the patients that I've seen at the bedside or in my research have said, people on the outside think that we don't want to get better, we don't want to get treatment, that we're not motivated, that we don't care of getting our kids back, or we don't care to preserve our heart valve so we don't have to have another surgery and so forth. And their stories have begun to shape the way in which we start to look at this problem from a deeper ethical position. And I'll give you the case of one young man, 22 years old, needed a second heart valve. Now keep in mind, when you have to get a heart valve replacement, whether you get a synthetic valve or otherwise, you will need a replacement within 8 to 10 years anyway. Okay, so chances are that 20-some-year-old, 30-year-old is going to get yet another heart valve in 10 years. Okay. This individual on a second heart valve, and the healthcare community that has tried to work with this individual kept on saying, he's resistant, he's non-compliant, he's a frequent flyer, all the names that people call patients, sometimes more derogatory than that. And he said, I do want to get better, but nobody will listen to me, that I can't go back to my home. My parents are using, my grandparents are using, my girlfriend is using. I don't have access to mental health care. I don't know how to get Medicaid. I don't know how to get a job. And so all these aspects are confounding this young man who keeps coming back to the hospital. And even though we would like to think, getting your child back or getting that next surgery or getting that treatment is going to be the solution, the resistance may not really be the genuine resistance that we seem to think. The resistance may simply be people aren't listening. People don't care. People don't really understand my particular story and my situation. And that, great, some people do have access to mental health care, but if we don't have access to mental health care services or think that we have access to mental health care services, there's just a cycle, and it's a damaging cycle. And so from that perspective, we see this over and over again. And I know Michelle was talking about this, that these are the patients that she sees coming over and over again.
And to add on to that, I feel as though the resources for the rich kids are a lot greater. And so there's this sense that I'm not doing enough for the lower socioeconomic status because they have limited insurance options and they have limited places to go. And, we give this narrative of, sorry, Dr. E, that someone had a prescription and it led to this life of addiction. And that is true for some people. But if we're looking at addiction as a bell curve, I'm convinced everything in life lives on a bell curve, FYI. those are the people over here, okay? Those are the people with the families that are able to articulate what happened. Those are the people that are going to journalists and telling their story. But the sad reality is that most of these kids, I'm seeing the seeds of addiction planted within childhood, because that's what they are. 9 out of 10 substance abuse users start using before their 18th birthday. And we know what the risk factors are: trauma, childhood abuse, parents are using, grandparents are using, grandma died. And so there are resources, but sometimes they're limited to those of us that are in higher socioeconomic status, or those patients whose parents are able to get them the care and able to fight for them, and sometimes they don't have a voice. Sorry.
With this being more medically induced, I kind of want to go on to another track of comparing like these two different fields. But within the AIDS epidemic back in the 80s, oh, thank you. Within the AIDS epidemic back in the 80s, people feared the unknown, whereas they do now with the heroin epidemic or the opioid epidemic. However, now we have a huge parade and festival and philanthropic movement for research, prevention, and cures for AIDS in New York City every year. Why don't we see anything for that with addiction or the opioid epidemic, especially when we have situations such as this with children?
Do you want to address that?
Well, keep in mind that even though these festivals and things occur with AIDS and HIV, we still see abuses happen every single day. We see it in research. In fact, New York City from 1986 to 2006 was targeting orphans for research studies with AIDS. And so we see, and I'm glad that you bring up other perspectives, because we see trends of abusing vulnerable populations. And our last panelists discussed that this epidemic is moving, and it's moving into our inner cities, it's targeting our minorities. It's gonna get worse before it gets better if we don't recognize problems of white privilege, if we don't start recognizing vulnerability in populations and looking at the kids that have been abused, the parents that we see slumped over the steering wheel with their child screaming in the background. Yeah, that image is there, but look at the magnitude of that, not just parent-child relationships, but the community that had to see that. And these images aren't enough. We have to recognize how the vulnerability is going to be affected. And like I mentioned before, the social determinants of health are there. And if we can't recognize problems in the workforce, problems in the environment, lead paint issues, et cetera, all of these issues are going to confound, and they're all related to this crisis.
I'm curious about your comments you made earlier about providers having problems with addiction.
How widespread is the issue of providers themselves with addiction? Is it just, a few people here and there, or is it a good percentage? I mean, is it possible for you to put a number on it, like the percentage of providers who are addicted?
Don't have the perhaps Dr. E has the statistics, but I will say in our community, we do have a problem of providers struggling with addiction, not just opioid addiction, but alcoholism and so forth.
Quantify that for us. How big is it?
Well, we'd have to look at the state medical board, at least from the medical providers and the nursing boards, to identify, and it's public knowledge of how many are actually going through treatment, may have their license suspended, but then you have a whole host of individuals that are undetected. I don't have the exact statistics, but it is prominent.
In terms of how widespread it is, anecdotally.
I've been on 3 court cases just in our Akron-Canton area with providers that have had medical negligence and malpractice cases, and those are 3 pain specialists. And pain specialists are not necessarily a common, but this is just within our area and just my personal experience. So.
And as I learned on one of Greg's podcasts, and he may even have numbers associated with this, one of the issues is, of course, there's a much higher level of acceptance of prescriptive behavior, especially amongst pain management specialists. And the medications are generally gratis and off the record. to the degree that they can be within a system. So the provider can sit there and sign in and get what they want, even if they're heavily into addiction, and essentially be a heavy abuser and off the system, to my knowledge, that is. And I gained that from one of Greg's podcasts, actually, with a guest he had on at the time. I can tell you that when I began this journey, or prior to beginning this journey, I was just building a practice, looking for the sort of conditions that a chiropractor might treat. Now, in 2018, I've had to spend my lunch break finding a table, or a facility for someone, because their doctor has essentially said, this isn't worth the risk anymore, I'm done with you, and I'm not going to prescribe for you anymore. And because they saw me on TV or in a newspaper article, they thought I had something to do with this, and show up in my office, and I'm spending time trying to find them recovery. I had one patient who stated, well, I'm not an addict. I was hit by a bus 20 years ago, and I've just been doing what my doctor told me to for 20 years. And I'm not an addict, so why are you trying to find me a recovery facility? I just need to find a doctor who doesn't abandon me. So that's an issue. One of my colleagues has a grand old lady that comes in her walker and says, I'll be fine as long as I get my hydro. And that's, her way of approaching it. And whenever I manage to get in a newspaper, she makes a cutting and brings it in and gives it to me and says, well, you go get him, it's too late for me, kid. And that's kind of her approach to the whole thing. And it is a question, if you're talking about, and there are a lot of them, an elderly individual who's addicted, to what degree do you consider recovery for an individual like that as opposed to just letting it go? There's an ethical issue in and of itself. Regarding children, lest you believe what is frequently being reported, and remember, my remarks are about prevention, so I'm not necessarily refuting other remarks because I'm dealing just with the issue of prevention and prescribing behaviors. I don't believe we've turned the corner regarding opioid prescribing. I don't believe that a lot of Ohio's physicians, especially non-hospital-based physicians, are fully in line with current prescribing guidelines. And what supports that is a recent report from the Office of the Inspector General that Al alluded to regarding opioid prescribing to Medicaid recipients in Ohio, indicating opioid prescribing at abusive levels is still highly problematic. During the OIG study period, which was 1 year, nearly 5,000 Ohio Medicaid recipients received high levels of opioids, well above recommended safe levels. Alarming to me is that during the study from May of 2016 to June of 2017, 40,000 children in the Ohio Medicaid system, not in cancer or hospice care, received one or more opioid prescriptions. The ethical duty of a parent is to protect their child. There is no safe dabbling in opioids for a child, nor in my opinion is non-cancer or hospice care opioid prescribing for children safe, and it is the moral obligation of the parent to intervene on the behalf of their child.
Greg, did you want to add anything to that?
I want to go back and revisit the issue of when you discover that your child has an issue, the challenges associated with facing that, if they're not prepared to do that. And you have to realize as a family, your role there, your role is to be supportive and not enable them. And you also have to realize that the brain has been hijacked. And when the brain is hijacked, they get so good at telling you what you want to hear. They are masters at manipulating you. And so you, without even knowing it, you could really make matters so much worse by enabling them. So if you have a loved one that's struggling with this, forcing them into treatment, in my experience, through all the people that I've talked to and through personal experience, that doesn't work. They have to be ready to go. You have to understand your role as a family member in terms of the best way you can possibly support them. And a lot of times that comes down to knowledge, understanding that role, and understanding what it means to enable. I'll use a painful example for you. We set aside set up a retirement account for Sam and funded that. And he's living in Florida. I think he's doing really great, but struggling to pay a bill. We make a deal. He says, "Can I tap into that one time?" I said, "Sure, Sam. You can, this one time." Now, our deal going forward, anytime that you've got an issue, we're going to talk about it. And maybe, if it warrants it, then we'll consider it and tap into it again. But this is a once only for right now. So, sure enough, he taps into it. And I forgot all about that until we lost Sam. And about a month later, I realized he had drained that entire thing. And he'd put $7,000, I'm sure, to support his habit there. And you know what? After the fact, I have to tell you, I was crushed by that. And I just didn't see that coming. I didn't see that. And so that's how your heart, your head can be in the right place. But gosh, you can get worked so easily. So
I want to ask each of you, what is the one thing, or maybe two things, or three if you want, but let's keep it to that, that you would do to help this, to move this forward, to make it work better, to get toward a solution? What's the one thing you do in your universe, and how would you answer that? Start with you, Patrick, since you...
Well, again, I'm a little bit of a one-message individual here. And the one thing I would do is attempt to overcome the barriers that are out there that are creating a greater immersion of the kind of care that my profession offers for pain management. I mean, we're talking something like 80% of prescribing was for conditions that are routinely and effectively dealt with by my profession. If you look back over the last 30 years of the genesis of this crisis, if we had had a what-if scenario where the public was accepting of a profession like chiropractic or acupuncture, and routinely sought that first before they would consider prescribing, I would argue that the opioid crisis either would not exist at all today, or certainly wouldn't exist to the level it does now. So our challenge is, how do we overcome those barriers? And those barriers exist within the medical community, still maintaining some negative perceptions of our profession, some perceptions of risk that are relatively non-existent. The media, I mean, when I first reach out to, and I'm constantly reaching out to the media, the usual response I get when I say I'd like to make comments about the opioid crisis is, well, what would you have to say about the opioid crisis? You don't even prescribe medications. So not really getting it is the difficulty I have. And I do have other remarks about that a little later. Thank you.
So the two areas, first and foremost, because of what's meaningful to me and my value system, is the education that I provide to my students, be they healthcare professional students that are developing and emerging into professionals, or the professionals themselves. And to have an advocate for them, to recognize when they're suffering, when they have moral distress, and to guide them in recognizing their own personal biases towards patients. That's my first and foremost duty. My second, as a researcher, is to start following a lot of our patients, to recognize the nuances, their stories, which helps us better understand our own biases, but to also see a deeper complexity of how maybe a community can connect and do better. Simple things like bringing those silos together that Michelle talked about. I mean, working with a heart surgeon and bringing in behavioral psychologists. I mean, those are just little steps but to recognize that there are gaps, there's serious barriers to accessing health and prevention. And as a community, we need to call attention to this, whether it's through education or research.
I guess I would say moving forward, it would move more towards a model of prevention. So we know, we like to give this narrative that addiction can hit anyone, and that's true. But the fact of the matter is that when you live in poverty and you live under trauma and you live under abuse, your rates of addiction go way up. And so I don't know how many of you are familiar with the Rat Park model. So the Rat Park model is by Bruce Alexander. He originally, I don't know how old a lot of you are. Some of you clearly are older than me, so I feel good about that. But they did those series of studies where they put the rats in the cage and gave them the morphine in the water, and then they just kept drinking the morphine. And he came along and said, rats are social creatures. Of course, what else are they going to do in these little confined cages? So he went out and built the Taj Mahal he called it the Rat Park. And they had rat friends, and they had rat activities, they had a little gym, they had a little bed, and they had this entire community behind them. And you know what? Most of those rats, some of them still dabbled on the opioids or whatever drug they gave them, but the vast majority of them didn't become addicted. And when we translate that, we can translate that into the human model, because we know in pediatrics, when you sustain trauma, when you have PTSD, when you grow up with drug abuse, when you grow up with out of focus on mental health, that causes changes in the brain. It's not as though there's a disease component to it. We know that. We know that we call them epigenetic changes. That's a fancy medical term for after your DNA is made. I compare it to a car model. When you make the car off the model and then you make aftermarket changes to it, that's what epigenetic changes are. And we know that these things repeatedly affect the brain. And the evidence shows is that those patients are the most likely to suffer from addiction later on in life. Those patients, Amelia hit this on the head without actually knowing the science behind it when she said the Playhouse Square saved her life. That was her Rat Park, okay? Because as she alluded to, she had risk factors for addiction, and her Cleveland Playhouse, or not Youngstown Playhouse, I'm from Youngstown, I should know better. Youngstown Playhouse saved her life, and for some of you, maybe it's the journalism and sharing these stories, and others, it's their family that has support. But if we continue to ignore this narrative, that we aren't setting the seeds of addiction by ignoring mental health, by not getting kids access the hope that they need, and even other people that have PTSD, we will continue on this path of addiction. Our suicides are up for very similar reasons, and the drugs will change. Opioids get a lot of coverage because people die sooner. But guess what? My meth addicts are still going to die. It's going to be from different things, and it's not as acutely, but they're still going to die until we move forward on this narrative on what our risk factors are and how we can treat them from the beginning, because I'm seeing the next generation of addicts every day within the walls of our hospital. And those are the kids that I don't have resources to always send to, and that they don't have a full-blown addiction, but if their parents aren't going to get them mental health help, I can see their path forming in front of me.
In 2015, these souls were lost through heroin-related overdoses in Palm Beach County. This is the Palm Beach County Post. My son's picture is on the bottom of this. He's part of that generation that was lost. Many in this generation were lost because they sent their kids, many from across America, down to Florida to recover with this idea that in 28 days they were going to be good as new and ready to resume their old lives. That's a fallacy. It's a lifelong disease. We know substance use disorder is a lifelong disease. And so it's my wish, it's my hope that we as a nation will come to grips with that. And rather than having a planning window that's somewhere in the neighborhood of 28 days for recovery, we'll think of it always in terms of 5 years or more, because statistics will tell you that's when you really have your odds skyrocket for success. And that's the way that we need to look at it as a nation. There's one other thing that I'd like to add, and that is when somebody decides that they want recovery, that's the equivalent of deciding that they want to climb Mount Everest. There's a lot of things that you have to manage when you decide to make that trek, that climb. And no one person can do that themselves. Well, recovery is no different than that. I actually, every time I speak, I like to give out these chips, and I'd like to offer each of you a chip. This has a silhouette of Mount Everest on it, and the symbolism of climbers climbing that. On average, in recovery, it takes for just one person to make it, if you will. They've got to have a lot of people surrounding them. Unfortunately, this disease is the disease of self-isolation, and that's how people die. So I'd like to ask all of you to take a chip, and the next time that you meet someone who's struggling with this disease, offer them the chip, let them know that you're on their team. You're on their team. I think this kind of support, if we can do that over and over and over again, that'll help to do away with the stigma that this terrible disease has. So, thank you.
We've asked some questions here. I'm a journalist. I can ask questions all day. But really, what questions do you have that we haven't answered for you yet? Anybody?
Hi, I'm not trying to delay lunch, Jan, I promise. I have a concern about the perception of addicts among nurses. Is there any plan or research going into how to overcome compassion fatigue? For all medical professionals, really.
Hear that question.
Was I not loud enough? I'm sorry.
Compassion fatigue.
Could you repeat the question? I didn't hear it either.
She was asking about with nurses dealing with patients with addictions, what steps are being taken to overcome compassion fatigue?
Yeah, so, I want to say health professions broadly, we tend to talk about physicians, but health professions broadly, I mean, our pharmacists, our nurses, our podiatrists, our physicians. And so I would say, I mean, going back to that question about how our cultures are starting to change, I am seeing more educational opportunities about calling attention to moral distress, compassion fatigue, burnout, and so forth. Now, calling attention to it is one thing, but actually doing something about it. Because, I mean, we all recognize healthcare professionals have long working hours, have patients with very complex, difficult illnesses and diseases. And so Michelle mentioned the Schwartz rounds that are at Children's Hospital. Those rounds are offered in several hospital systems where you have a panel such as this talking about a case, a situation, a dilemma, so that healthcare providers can debrief and, not just feel socially isolated from those experiences. I'm also seeing more healthcare providers that are building teams surrounding debriefing sessions and having the opportunity to reflect, talk about the situation, and come collectively together to remedy some of this. Now, working hours, unfortunately, we need to readdress the long working hours, but in terms of actually acting as a community and being supportive of each other, I'm seeing a new developments and changes in that within hospital systems. Now, the home health aides, area agencies on aging, some of the smaller groups, we need to start working with our smaller agencies to do the same thing. I'm seeing it more at the larger clinics and hospitals, but we need to work with folks that are going in our rural communities and so forth. So, but it is emerging.
I would say that sometimes being in the peds world is a little bit hard because it's sometimes easier to have compassion for children than adults. And so some of our views are a little skewed, but I'd like to not discount the role that all of you have in providing compassion fatigue and addressing it. There's a lot of reasons why we have compassion fatigue, and it's not just addiction. But when you all shape the narrative of addicts as humans with families, sometimes that brings a different side of the story to them that they can see. And I know as a healthcare provider, the cases that hit you the hardest are the ones that are most like you. right? And so that you can see yourself in those shoes, or that you feel so terribly awful for. Not to say that, you try hard to maintain the same level of care for everyone, but you all have a role in that as well when you shape this narrative of addiction, as a disease, and the struggles that people have to get treatment and the options for them. Also, it's an important role. We're members of the community as well.
Hi, so I have a question. About 10 or 15 years ago, when higher education institutions started paying a lot of attention to issues regarding students with mental health issues, they started passing on that education to teachers and to professors. Should we be doing the same thing with addiction and recovery resources? I believe you said the seeds of addiction are sowed in childhood, so should we be tackling both of those issues at the school and the higher education level as well in classrooms?
Yeah, if you look at the data, and you can go to SAMHSA's website, which is what is the full name? Substance Abuse Mental Health Society. I forget what SAMHSA. NIDA has it too, the National Institute of Drug Abuse. They have a lot of evidence-based medicine and evidence-based practices that early interventions in pediatrics, and not just the kids that I'm thinking of, my 9-year-old on LSD, the 12-year-old that overdosed on cocaine. But they actually have interventional models down to preschoolers that are having emotional regulation issues, to intervene with them to help. So yes, it goes all the way down to the preschool level. There are initiatives that are looking at bringing that in for teachers and for educators to kind of recognize those, to get these kids help a little bit sooner. Mental health is still a stigma that we have a lot, and I'd still say it's completely underdiagnosed. But yeah, there are models for that being done, and it's what we're pushing forward through our addiction treatment center at Akron Children's, is really going into the communities and focusing on those kids at risk.
There's also firehouses, police departments and so forth are working with some of our smaller rural communities. They're actually teaching junior high schoolers how to use Narcan. I hate to say it's come to this, but it's education, and if their parents are overdosing, these kids are able to use these medications without fear. And just the example of having this educational opportunity for you guys of how to use it, that's for some first steps, because it eliminates some of the fear and possibly even some of our personal biases surrounding the disease.
To that point, that is exactly my question. The Surgeon General of the United States has encouraged all Americans to carry Narcan. Yet we know it's in too few places available here. We'll have a training event next week, as you mentioned, but it's not available in our residence halls. I would like to talk to the panel, get your views on whether you believe all Americans, all walks of life, should be trained and should have available Narcan.
I'll weigh in on that. Yeah, I believe that if you have a loved one that is taking opioids for, has a prescription, legitimate prescription, or if in a, worst case scenario, if you know someone who's addicted, a friend or family member, then absolutely, I would highly recommend that. And it's really easy to do. Going to a dawn course it takes you a half an hour, and they're readily available. And every week they put them on in Summit County, and I'm sure it's the same here in Portage County. And I know they've got a bunch of them up in Cuyahoga. And so it's a simple thing to do. It's a good idea to do, and it's a very easy thing to use. Harm reduction is something that I think everyone should play a role in that and get involved in that and educate themselves and understand that the things that you do can make a profound difference in the community. Another important piece for harm reduction are the disposal bags, these deterra bags. We don't even think about that. You go, you have surgery, you get prescribed, and then you got medicine that's sitting in that medicine cabinet, and it never even dawns on you that somebody could open up that medicine cabinet and help themselves to whatever. And you like to think the best in people and what have you, but you could be showing your house and, the realtor brings in whomever, who knows, or there's a party, who knows. So getting those out of the medicine cabinet, it's a great thing to do, and it's an easy thing to do, and very, very convenient. This, all you do is put water in this, you open it up, put water, pour in the pills, close it up, throw it in the garbage, and you're done. So here's a controversial thing that I was hoping the opportunity would present itself to share this, and I'm going to share it now. This is really controversial, and I suppose that's one of the reasons why I like talking about this. There's somewhere in the neighborhood of 85 to 90% of the heroin that's in Northeast Ohio is laced with fentanyl. And if somebody's going to use, they're going to use, period, regardless. But if they have an opportunity to test with a fentanyl test strip, these cost $1. Very simple, it's just like an EPT test. Then studies have shown that they will probably, if they determine that there is fentanyl in there, they're going to go slower and be more cautious. They'll use less. And they may even take a test shot. And this $1 could be the difference for them making it that extra day, and maybe, who knows, maybe tomorrow's that day where you talk to them and you get them the help that they need. You get them into treatment. That's a simple thing. Now, talking about it, it's not easy to do because a lot of people think that's enabling, that's really, and until you begin to really accept the fact that this is a chronic brain disease and their brain has been hijacked and it's not moral failing, until you truly understand that, then those people are just going to believe that. But we keep on, and ultimately, at some point in time, at some level, we'll chip away at the stigma with things like that, talking harm reduction. Harm reduction saves lives.
It's not dissimilar to what they did with ecstasy back in the, with the rave days when they test to see if it was tainted or not. To address your question, when I am posed with questions like this, from an ethics standpoint, I always think, what would I say if it was a different disease state? Okay, and so I always try and hearken it back. And to me, I look at something like asthma and albuterol inhalers, or I look at an EpiPen. And is it cost effective to have the entire world have an EpiPen? No, but would it save lives? Yes. So instead, I think we should approach it personally from a strategic location, not similar to the defibrillators that are located in major, that we know that there are at-risk areas in places of business maybe should have them, and, community centers should have them, and at-risk individuals, if you know someone's using, or maybe we can dispense them with opioid prescriptions just in case. When we have a kid on opioids on the floor, they automatically get a naloxone order as well, and that's therapeutic use, just in case. And so I think from an ethics standpoint, I would approach it from what do we do for other disease states? And in that, we hit targeted populations and targeted specialties. So if you have a heart attack in McDonald's, there's a defibrillator there to potentially help you out. If you know your relative has, XYZ, an anaphylactic reaction to bee stings, you carry an EpiPen, they carry an EpiPen, everyone carries an EpiPen that's around that person.
Greg, where would we ideally distribute those test strips?
Well, ideally, you would start off with the needle exchange, and that's what we did in Cuyahoga County. It's the largest syringe exchange in Ohio. They give out somewhere between 500,000 and 750,000 syringes per year. And the most important thing to note here is it's a compassionate service that allows us to keep the community safe from HIV and safe from Hep C. And I presented the idea to them and told them, okay, Cover 2 would like to sponsor your first 500 of these. And sure enough, within 5 minutes of that discussion, we sat down with the CEO of the Adams Board of Cuyahoga County, and he chipped in $15,000. So now that's a full-blown program. And there's other needle exchanges in the state that are looking at that and would like to emulate that. And it's perfect for an addition to their number of tools that they have in the bag for harm reduction. But make no mistake about it, these folks are passionate about what they do, and every single day they're talking to their clients. They get to know them very, very well, and they're trying to help them with the myriad of issues and hope that one day they'll have an opportunity to get them the help that they need.
Oops, one more question.
I'd like to ask about a harm reduction strategy that's even more controversial than the test strips. In some countries,
I said, I'd like to ask about a harm reduction strategy that's even more controversial than test strips, and I'd love to hear your thoughts on it. In some countries, they've gone as far as to have heroin injection sites. Yeah. And if this truly is a lifelong disease, what do you think, what does the panel think about that idea of having heroin injection sites in the U.S.?
Is that to me? So, yeah, safe injection sites throughout the world, you've got over 100 of them now. There's only one right now legitimate safe injection site in North America. That's in Vancouver, that's Insight. And they're having really good success, very good success. In New York, Seattle, and where else? Philadelphia, they're looking at that. In New York, they have one that really is not, it's a public John that they kind of dressed up like that, but they haven't passed the legislation to do it, but in effect it is that. So safe injection sites are, I think they're positive because of the fact that they, if somebody's going to use, they're going to use, so it sets up an environment whereby they can go in and they can be monitored and they can be safe. Nobody's overdosed and died in Vancouver. In Insight. That hasn't happened, and they've been around for a very long time. So these are things that are really good to look at. And I think, you know, we'll see in our country how well they work, and we'll see that in the next 5 years, I believe. I think in New York and Seattle, they'll get them going. In the meantime, though, there's so many other programs that are working and working well, and we don't have to pass legislation to make them happen. There's so many communities that are doing so many good things, and those are the things that we need to do the best that we can to shine a spotlight on those and propagate those wherever possible. Those are the things that we can do. Last spring, I went to Atlanta for the Opioid and Heroin Summit that they had down there. And their keynote was President Clinton. And he made a really, really good point. He said, let's go after the low-hanging fruit. Let's go after the low-hanging fruit. So start there. And guess what? There's a lot of it out there with programs that are working and working well.
Thank you, panel, for your insights. Thank you, audience, for your questions.